So thanks, Yolanda, and thanks to the meeting organisers. It's very exciting to be here and see the meeting so well attended, and I hope that there'll be other meetings like this in the future that we can all learn from. Now, I've been asked to talk about the diagnosis of MPNs, so although I'm both a clinical and laboratory haematologist, I'm here with my pathologist hat on today. Later in the session, we're going to have a talk from Wendy Erber on bone marrow morphology, so I've tried to steer away from that to some extent. It was a little difficult to prepare this talk because I don't know how much people know. I know that some people very actively research their condition and will have quite a lot of detailed knowledge, and other people will have a much more basic understanding, so I've kind of tried to pitch it somewhere in between. So I was given the title of Diagnosing MPNs in 2017, and I think that to know where we are now, it's always useful to take a historical perspective and see where this area has come from. I'll then talk briefly about each of the three major diseases, polycythemia vera, ET, and myelofibrosis. And then a little bit at the end, because I think there's going to be more on this later in the meeting, I'll talk about some of the molecular complexity of myeloproliferative neoplasms, which really is staggeringly complex. So in many ways, this field started almost 70 years ago now with the recognition of a Russian-American hematologist, William Damashek, who is the president of the American Society of Hematology, who made the observation that there was a cluster of diseases which share overlapping clinical and pathological features. So he says here that this group of diseases, the cells often proliferate en masse as a unit rather than as single elements. So an increase in white cells, an increase in platelets, and fibrosis in the marrow are seen in a group of diseases. And he lumped them together for the first time and called them myeloproliferative syndromes. Now, a syndrome, which is Greek, like so much of what we talk about in medicine, is a group of things running together. That's what syndrome means, and that's why we have aerodromes and hippodromes and things, because they're places where things run. So it's simply a collection of things that tend to happen together. Now, that essentially is a descriptive term because we don't really know what the underlying cause of this is. It's simply a collection of things that we observe happening. Now, obviously, a syndrome could have multiple possible underlying pathological causes. So what are the overlapping pathological features of these diseases? So if you look at this chart, they're basically all the same things listed here: enlargement of the spleen, fibrosis in the marrow, high white cell count, high platelet count, and then the last one is high red cell count. So you can see that the first four occur in every one of these three diseases, but to varying extents. The only one which is unique is erythrocytosis, which is the hallmark of polycythemia vera, and its presence essentially defines PV, so that the other two lack erythrocytosis. But all of the other features are overlapping, and they just vary in the degree of prominence in a particular disease. And what I haven't put on here are the symptoms or the clinical problems that patients experience. So an important feature of all of these diseases is an increase in the risk of bleeding and clotting complications, which are a major cause of morbidity. So we had this term myeloproliferative diseases or myeloproliferative disorders that was current for half a century. In fact, the individual disease descriptions go back even further. So the original cluster included chronic myeloid leukemia, which was the subject of my PhD. That was first described almost simultaneously, almost about 150 years ago, by a Scotsman, John Hughes Bennett, and a German, Rudolf Virchow. And it was recognized quite about more than 50 years ago now that almost all cases have the Philadelphia chromosome, and they have a specific treatment which makes them different from all of the other myeloproliferative syndromes, and therefore CML was deleted because it's its own special group. And then that leaves the other three diseases So a German pathologist described myelofibrosis with myeloid metaplasia back in 1879. The myeloid metaplasia refers to the growth of marrow elements outside the bone marrow. So that's what the metaplasia means. It means growth where it shouldn't be. And this refers to the enlargement of the spleen, enlargement of the liver, and rarely even little deposits of marrow tissue in places where they shouldn't occur. Then I learnt yesterday from Cecily Forsyth that Henri Vaquet was a cardiologist, not a hematologist, which is a shame on the profession. And in 1892, he described what was known as polycythemia rubra vera. So polycythemia basically means too many cells in the blood, red, true. So the polycythemia rubra vera, the rubra was dropped some years ago in recognition of the fact that it's not only red cells that are high, but white cells and platelets as well. And so it was considered more precise to say that it's polycythemia vera, that there are too many of all types of cells in the blood. And then there's quite a big gap until 1934 when these two people described essential thrombocythemia. And I think it's no accident that the diseases were discovered in this order, because I think it reflects the fact that people with the earlier of the diseases tend to have a higher symptom burden. They have a more obvious clinical presentation. So over 100 years ago, when people were relying on seeing really quite gross changes, these were the things that were picked up first. And in fact, part of the reason why ET was described so late was that it was actually very difficult to count platelets in the blood. Because they're so small, there was no very accurate way of measuring them. So while we take it for granted now that you can stick a sample in a machine and get a platelet count 10 minutes later, back in the 1930s, that was simply not possible. So that reflects the late recognition of ET. So skipping forward a bit, in 2001, the World Health Organization brought out its first classification of tumors of the blood systems, and they included a section on myeloproliferative diseases. In the update in 2008, they changed the name to myeloproliferative neoplasms. And that may seem like a minor change, but I think that names are actually very important. And I think that MPN is an area that suffers somewhat because its name doesn't have the immediate impact that the names of some other diseases have. So if someone says, I've got breast cancer, everyone knows what breasts are and everyone knows what cancer is. But if you say you've got a myeloproliferative neoplasm, well, people can't see it. They don't even really know what it means. And I think that means that the diseases have to a degree been neglected. So this sort of links into a question that I have been asked many, many times by patients that I'm seeing for the first time with a new diagnosis of PV, ET, or myelofibrosis. And people ask, well, is this a cancer? I mean, the fact that I sit in a building that says at the door, cancer center, is a bit of a clue. But the answer to that question is actually a little more difficult than it may at first seem, because as is often the case, the answer is yes and no. So for me as a pathologist, a cancer is a disease with abnormal cell growth and behavior. The cells are growing too quickly and they've taken on abnormal properties that the healthy cells shouldn't have. These are diseases that we treat with chemotherapy or radiotherapy. And importantly, in MPN, these are diseases which have potential to transform into acute leukemia, which is undoubtedly a very serious cancer. Now, that risk is very small, for instance, in something like ET, but it's there, and I think it's important that people be aware of it. So from these points of view, MPNs are cancers. If you think about it in the way that people normally think about cancer, sort of in the broader population, the answer is definitely no. So these are not lumps that invade the surrounding tissue. You can't, if you find them in an early stage, you can't cut them out and be done with it, or zap them with radiation and be done with it, because they are by definition throughout the body at diagnosis, because they are blood disorders. And importantly, with the possible exception of myelofibrosis, they're not a major cause of death. So most people with an MPN will not die from their MPN. Many people will live with their MPN for many, many years, unlike something like prostate cancer or pancreatic cancer, where many people will die within a few years from their diagnosis. So I think there are some similarities, but there are also some important differences. The scientific evidence so I think myelofibrosis can be a very nasty disease, and I think there's no doubt that it behaves like a malignancy in many cases, particularly advanced myelofibrosis. With PV and DT, it was a little bit harder. So in 1974, one of the two Prakal brothers described this thing called BFUE. I don't know if any of you have come across it. This is an erythroid burst forming unit, or erythropoietin independent red cell colony. And so these are, when you take the blood from somebody with PV or ET and you put the cells in a petri dish, some of them will grow in the absence of normal growth factors. So this ability to grow outside normal control mechanisms is one of the hallmarks of cancerous cells, and so we can see this. We can see this in people with JAK2 positive PV and DT. A few years later, Fialkov described the X chromosome inactivation patterns of these diseases. So this is something that you can only do in women. So because men only have one copy of the X chromosome, women have two. So in every cell in the body, you have to turn off one of your X chromosomes if you're female. You either turn off the one you got from your father or the one you got from your mother. In every cell, this is random, and every cell will be different. But if you have a cancer where all of the cells have grown from a single origin, they will all have turned off either the maternal or the paternal X chromosome, because they've come from the same origin. So if you look in the blood of someone with polycythemia vera, and you may well find that they've turned off entirely the paternal chromosome or entirely the maternal chromosome. So again, this is a way of showing that these are abnormal proliferating cells. And then finally, the major breakthrough came in 2005 when William Van Schenker and several other groups around the world, including Tony Green in Cambridge, described the JAK2 V617F mutation, which was amazingly found in about 95 to 97% of polycythemia vera patients, in about 50 to 60% of people with ET or myelofibrosis, and very rarely in a smattering of other related myeloid diseases. And then, of course, subsequently, the MIPL mutations were discovered, and then the calreticulin mutations most recently. So polycythemia vera is defined in the most recent edition of the World Health Organization classification as a high hemoglobin, so the cutoffs are written here, or a high hematocrit or packed cell volume. So the packed cell volume is a very simple test. You take a tube of blood, you stick it in a machine and spin it, and it packs it down, and you get the cells at the bottom and the plasma liquid component of the blood at the top. And the percentage that's solid versus the percentage that's liquid is the packed cell volume. So a very simple, very cheap test. And interestingly, for reasons that aren't particularly clear, the treatment target in polycythemia vera is based on the hematocrit, even though much of the world uses the hemoglobin cutoff as the diagnostic criterion. There's also this test called red cell mass, which relatively few hospitals still perform, where we can actually measure the volume of red cells and the total volume of the blood by injecting a radioactive dye that's linked either to red cells or to plasma proteins. But in addition to this increase in red cells, you also have to have a JAK2 mutation, which in about 95% is V617F, and in about 2 to 3% of patients is an exon 12 mutation, which is just nearby the V617F, which is exon 14, together with bone marrow panmyelosis. And bone marrow panmyelosis looks like this. So this is a 76-year-old man, one of my patients. So if you look here, the white spaces are fat. So the fat is dissolved in processing, leaving only the cells. And essentially, the percentage of fat in your marrow should be approximately 100 minus your age. So if you're 25, you should have 75% cells, 25% fat. And if you're 75, like this man, you should have 75% fat, 25% cells. So you can see that this is the wrong way around. This is markedly cellular. And when you look at it, I'll let Wendy explain things in more detail, but there's a mixture of all of the different types of cells that should be in the marrow, and that's why it's called pan-myelosis, because everything is increased. This is essential thrombocythemia, so I hope that by seeing the two photos in rapid succession, you can see that here we have much more fat and less cellularity. So this is a normocellular marrow, and the numbers of megakaryocytes, which I don't know if I can get my pointer there. Let's see. So here is a small cluster of megakaryocytes down here. Here is one absolutely gigantic megakaryocyte. So this is why they're called megakaryocytes, because you can see in comparison with the other cells of the marrow down here that these things are absolutely gigantic, and so that's why they're called megakaryocytes. So the WHO defines ET as a condition with a platelet count of more than 450, which is sustained. A bone marrow biopsy, which could be summarized as being essentially normal looking, except that there are too many megakaryocytes, and the megakaryocytes themselves don't look too bad. That's essentially a very short version of what ET should look like. And this should be accompanied by the presence of a JAK2 calreticulin or MPL mutation. So as I said before, JAK2 is seen in about 50 to 60% of cases, MPL in about 5% of cases, calreticulin in about 20 to 30% of cases, and that leaves somewhere around 10 to 20% that have none of these three mutations. And those are an area of significant diagnostic complexity, because essentially if you look at the bottom note here, in the absence of one of these mutations or other clonal markers, something to say that this is definitely ET, you simply have to have excluded alternative possibilities. And of course, how can you ever be sure that you've excluded every other possibility? You have to make a pragmatic effort to make sure that there's not an obvious underlying cause, because the platelet count is increased in iron deficiency, it's increased in people with chronic inflammatory diseases or infections. So the platelet count can also increase in other blood disorders that may mimic ET. So it can be surprisingly difficult to make sure that everything else is ruled out, which is why it's enormously valuable from a diagnostic perspective to have a mutation that you can say defines that this is truly a neoplasm of the blood. So myelofibrosis is defined as fibrosis in the marrow with megakaryocytic proliferation and abnormality, quite conspicuous morphological abnormality, not reactive, accompanied by a mutation, and with these supporting evidence of leukoerythroblastosis, which is the emergence of immature red cells or white cells in the peripheral blood. These are cells that should normally only live in the marrow, but because of the marrow disturbance, they have come out into the peripheral blood. An increase in lactate dehydrogenase, which is an enzyme that's present in all blood cells. So the high LDH reflects the higher mass of blood cells. Enlargement of the spleen or anemia. Now, in the WHO 2008, there was this little footnote which said, in the absence of fibrosis, you could also have a hypercellular bone marrow with granulocytic proliferation and maybe reduced red cells, and that this was pre-fibrotic or early myelofibrosis. And this has been a huge area of contention among pathologists, because it really rests on recognizing the megakaryocytes as being morphologically abnormal. In last year's update to the WHO classification, this pre-fibrotic myelofibrosis was promoted to have its own section rather than just being a little footnote at the bottom of the main MF section. So I think it's clear that pre-fibrotic myelofibrosis must exist, because you can't just turn up one day with a marrow that's heavily scarred and 2 days ago I've had a normal marrow. There must be a process over time in which the fibrosis is laid down. So I think conceptually it must exist, but can we reliably distinguish it from ET? I think that's a much more difficult question. So just to give you some indication of how complex this is, these are examples of essentially funny-looking megakaryocytes, and depending on what type of funny-looking appearance it has, every megakaryocyte will look slightly different. So you have to decide, do more of the megs look MF-like, or do more of the megs look ET-like, in order to classify them into a particular box. So in ET, they're classically very large, with what's described as a staghorn nucleus. So I'll use the pointer because I can't point at both sides of the room at the same time. So this I think you'll agree, for anyone who's seen a deer, this reasonably looks like a staghorn. So this is the classical staghorn megakaryocyte. But for instance, here, this is also described as being a staghorn megakaryocyte. And I think if I saw a deer with antlers like that, I would be very, very unhappy. So there has to be a degree of imagination in applying these descriptive labels. This one, I think, is a little more convincing. This is the cloud megakaryocyte. Now, again, it's a slightly funny-looking cloud, but I think you can agree it's kind of got this frothy, bubbly look that's almost like a brain-like appearance. And then the other feature that's supposed to help us is whether the megakaryocytes are loosely clustered with other cells scattered between them, or whether they're tightly clustered where the cells are really wedged up against one another. As you can see in this image here, they're kind of sandwiched together with nothing between them. So features like this are supposed to tell us whether it's ET or myelofibrosis, and I think you can see how difficult this can be in individual cases. And I'm sure that Wendy will illustrate some of these difficulties better. And I think this is almost my last slide. I don't know how I'm going for time, but excellent. I don't want to get into trouble. I'm afraid of Anne already, so she might not invite me back. So I've talked about JAK2, MPL, and CALR, and I think that most of you will be familiar with those mutations, but it's clear when you go looking deeper that there are far more mutations, that those three things that we use for routine diagnostic purposes are really only scraping the surface, particularly in myelofibrosis, which I guess is in many ways the most complex of these diseases. So this is a selected number of mutations looked at by Alessandro Vannucchi from Florence. So the Italians have been, anyone who's done any reading will realize that the Italians are really major leaders in the field of MPN. And you can see, so that this is called a Circos plot, and the size of these bands reflects how often those two genes are mutated together. So for instance, this enormous red band here is people who have both a JAK2 mutation and an ASXL1 mutation. Then this sort of pinky purple one here is people who have both TET2 and JAK2, and you can see how complex the pattern is. So, and this I have to say, this is only Sanger sequencing, which can only pick up mutations which are present in around 20% of the sample. If you did this, if you took the same patients and retested them with next generation sequencing, which can pick up 1 or 2%, you'd find even more. So this is just scraping the surface of the complexity of these diseases. And importantly, it's been recognized, firstly, that some of the patients who have no mutation in JAK2, MPL, or CALR, so this is about 10 to 20% of myelofibrosis and ET, will have one of these mutations, so that could potentially be diagnostically useful. And also that the presence of one of 5 of these mutations in myelofibrosis, or at least in primary myelofibrosis, is associated with an adverse prognosis. And those are ASXL1, SRSF2, IDH1, IDH2, and EZH2. Now, most laboratories around Australia wouldn't offer these as routine diagnostic tests, but I think that most of us in the MPN field feel that in the not too distant future, these should become a routine part of our diagnostic and prognostic workup. So I think that it's not just access to drugs that's important for MPN patients, but even access to diagnostic tests, because there's a lag between researchers discovering these things and for those of us in a country where the public health system funds most of our tests and treatments, where the government recognizes that it's worthwhile spending public money on performing these tests. Now, as with all technology, the cost of these tests comes down very quickly with time. So what once cost $1,000 will cost a couple of $100 a few years down the track. So I know that, for instance, the Peter Mac here in Melbourne as a research project is offering a limited next-generation sequencing panel, but I think that they will probably become much more routine within the next 5 years around Australia. I know that some of the centres in America are already doing this routinely. So to summarize, the MPNs are important in that in order to make a diagnosis, you need a collection of clinical information, pathological information, and molecular mutation information to make an accurate diagnosis. I think that the three main mutations are just the beginning of things, particularly in myelofibrosis. For me, as a working laboratory hematologist, the morphological distinction between ET and early myelofibrosis, sometimes even between ET and PV, can be very difficult. And triple negative ET, and to a lesser extent triple negative myelofibrosis, pose something of a problem because we just don't have that thing we can say, well, yes, you've got this mutation, yes, it must be an MPN, and it's definitely not a reactive condition.